this really has to be their decision too, because this is a permanent change that they're making to their body, and some of this cannot be undone.
The reverse is also true. I find a lot of teenagers are way more open than other adults. So it just really depends on the teenager and your patient.
Bullying exists not only at school and in the playground, but also on social media and through those channels, or even text messages with their phones, since many.
Don't be maybe too aggressive with what other people have, celebrities, other things like that.
The beauty scientists, Dr. Kristy Hamilton and Dr. Roy Kim. Real beauty without the hype.
Welcome to the Beauty Scientists. We are board certified plastic surgeons. I'm Dr. Kristy Hamilton here with Dr. Roy Kim. We're in Houston, San Francisco, and we are talking about teenage plastic surgery today, which sounds controversial. There's three main surgeries that we do for teenagers. We're going to talk about them and why they really aren't controversial at all. We'll go into the ethics of them too. So teenage plastic surgery is I wouldn't say it's an increasing trend. It's not a trend. I think it's been very, very stable in terms of what we do in the pediatric population. And these are for older children. We will reserve a separate topic for congenital anomalies. So conditions that patients are born with, like cleft lip or cleft palate, which of course we address much younger. So these we're talking about surgeries that we do for teenagers, thinking about the nose, the ears, and actually large breasts. So Dr. Kim, what do you find are motivations for surgery for this patient population in general?
I think the biggest thing is social pressure. There are, of course, functional considerations, aesthetic considerations, but as we have a stronger personality, I think if we're adults, then maybe we can withstand some of the societal pressures. As a younger adult or teenager, I do think that society exerts a huge amount of influence on you. And if teenagers have parents around, family members around, and even really close family friends, those are the positive and supportive sort of pillars, that, if you will, before you consider having plastic surgery. What do you think?
Yeah, I think we see bullying can be a major issue, and we're talking about really prominent ears or ears that stick out. Patients will come in saying that they're being called Dumbo. It makes them, sad. Same thing with very prominent noses, having that kind of pointed out as their overarching facial feature. And I think in this day and age, bullying exists not only at school and in the playground, but also on social media and through those channels, or even text messages with their phones, since many teenagers have those now. It can just turn into this echo chamber where you can never escape it. So that can be a reason to pursue surgery, and we'll get into the ethics of that. I think for breast reduction, I find that when those patients come in, certainly other kids can be a factor, but oftentimes I find that these young women they're athletic. They feel like just like a adult breast reduction candidate. They just find that their breasts are getting in the way of their life. And so it may not be a bullying issue there. It may just be like, I'm a cross country runner and my breasts have tripled in size in the last 2 years, and now it's difficult for me to do that. It hurts. So I think face tends to be more social impact and social concerns, and then breasts, and from my practice, tend to be more functional. How do you have those conversations with patients, and how do you find that balance between the patients are obviously minors, so this is not they're not the one signing on the dotted line here, but also they're almost adults.
Yeah, I try to have two separate conversations. I try to have a conversation with the patient, and of course with the patient and their parents. And then oftentimes I may even have a third conversation separately with the parents. So I do think the consultations take longer, but I think you and I have been pleasantly and interestingly surprised by solo conversations. We obviously want to make sure that the patient wants a procedure, understands as much as possible all the options, and that they have the full support of the family members and parents that often do have to sign on the dotted line. And I think what's interesting as well, because we do a lot of social media, parents may not fully realize the amount of bullying or social media influence or celebrity culture that occurs today. Of course, we've always had fan magazines and we've always had bullying, but with our magical devices, it can be constant, late at night, weekends, during the summertime. Whereas growing up, I mean, it's not like you're hanging out with your friends from high school or even college all the time. But I think a lot of young people do feel that sort of pressure unintentionally.
Yeah, and you get no built-in breaks like a summer vacation or even weekends, to your point. So, how do you distinguish between a patient that would benefit perhaps from two of these surgeries, which are aesthetic, the breast we consider more functional, versus how do you distinguish between that cohort and then perhaps like body dysmorphic disorder, body dysmorphism, where the patient more, it's like, and we see adult patients with that too, where they kind of see a nose that's huge, but in reality, it's maybe not as prominent as they experience it.
Yeah, I think that BDD, body dysmorphic disorder, we're looking for the same factors, the same signs. I think in teenagers, especially, it's harder sometimes to draw them out. So you have to have maybe a more intense conversation, maybe be able to really ask them questions where they feel open to tell you. The reverse is also true. I think I find a lot of teenagers are way more open than other adults. So it just really depends on the teenager and your patient. And of course, the red flags as well as the green flags are same or similar, whether it's a teenager or adult. And especially with teenagers, because we are surgeons, it's very important to have them fully understand, hey, here's some options and non-surgical options or postponing it until they're a little older. And the other impetus, of course, is physiologic. It's the end of puberty. So when you're really done with puberty, I do think that, boys slash young men can still continue to grow into technically past the age of 18. Having those realistic physiologic, true biology concerns, you have to convey that to the patients as well.
Yeah, and I like you. I like to see a very mature minor because, like you said, like if we're operating on them when they're 16 or 17, I mean, you wait a couple months and they would be the ones signing on the dotted line. So I make sure that while their parents are signing, this really has to be their decision too, because this is a permanent change that they're making to their body, and some of this cannot be undone, depending on what operation they're choosing to have. And so it's so important that they feel very confident about the process and know themselves. And similarly, you have to have supportive family because they are kids, and you need to make sure that they're getting all the appropriate psychological support and physical support after having a surgery. So I think one of the first ones that comes to mind is rhinoplasty. What considerations do you have for the pediatric or almost adult rhinoplasty that's different than when we're dealing with a fully mature nose?
The biggest one is continued facial growth or rhinoplasty growth. In other words, we need to make sure that your puberty cycle is done with and that your nose actually isn't continuing to grow. In a lot of patients as well, it's a functional and aesthetic procedure. So whether breathing is a concern, a lot of my patients have broken noses or trauma. We just need to tell them that, hey, we are actually fixing them physically in terms of their passage, the nasal passage, the airway, the breathing, and that will help a lot. And finally, don't be maybe too aggressive with what other people have, celebrities, other things like that. Your nose is your nose. It has to fit your face. And so we want to give them an aesthetically pleasing but holistic result to teenagers. Well, how do you console your patients?
Similarly, I tell patients I think filters of their own face can be very helpful because it's kind of an adjustment of their own nose, but you're not going to transplant someone else's nose on top of it. And to keep in mind that these social media figures that they may be bringing in inspo pictures of, they often on top of that have a filter and contouring, makeup contouring. So when they see these like really tiny pixie noses, a lot of those don't even exist in real life. And even if they do, it may not be appropriate for their own face, or it just may not be achievable based on their bone structure and the starting point. So it's all about where we're starting and then where we're going. But rhinoplasty, very powerful operation. You can really, really change things. I mean, it's one of those moments in my practice that I just love when you take off the cast and you show patients for the first time, whether young or old, and they get these tears because it's just such an impactful change on their face. And to your point as well, we want to make sure that we're not going in too soon. So I think a great time to perform these procedures is the summer between high school and college. The youngest, I think most people will do rhinoplasty, including myself, is 16. But again, it varies a little bit, girls versus boys. You want to wait until you're not seeing rapid nasal growth because you don't want to continue to have growth afterwards or potentially stunt the growth of the nose. So I agree with you. It's a functional as well as an aesthetic operation and can be completely life-changing. And some patients look so different before and after their rhinoplasty. I think that's why that high school to college transition can be nice, because it's also a social time to, as a reset, start over, new set of friends. Breast augmentation, or sorry, breast reduction. We're not doing those for kids. Breast reduction. Actually, I guess there is a small role for augmentation, which we can touch on too. But when are you recommending patients consider breast reductions? What are some like lifestyle and physical features that you're looking out for to know it's time?
Yeah, I mean, you touched on this before. Really, the breast reduction patients I'm looking at are very athletic. And so we need to make sure that puberty is done, that patients realize that breast reduction is a permanent thing. In other words, we can't really easily replace the breast tissue itself. And the other good news is that typically it does not really have an effect on future lactation or ability to produce milk. So those are all key factors. And finally, it sounds strange, but it's very true. It's important not to go too small because you can't easily add any breast tissue. And this is true for breast reconstruction patients in general, but especially in teenagers, it's very, very true.
Yeah, so they may change their mind as time goes on. So I think I like to see a very mature patient, one that really knows what she's looking for, feels confident in that decision-making process, because it is a permanent change. And yes, I think we try to keep things very proportionate for the pediatric breast reduction patient. And I still talk to them about things like lactation, even though they may be so far away from that. But I think, they're mature, these young women, and it's important that they understand all the benefits, risks, and alternatives, just like their parents should when they're signing the consent form. Again, I think when we see breasts that are really big, we know that they're not magically going to get smaller on their own, and that's why I'm so comfortable performing these procedures in the older, like teenager population. If the children are not at an ideal or normal weight, I like to encourage them to get as close to that, maybe with working with their pediatrician or nutritionist, because that can impact breast tissue. But I think even more so than the adult population, a lot of times these young girls are at a very normal BMI and they just happen to have specifically a lot of breast tissue. And so has nothing to do with their BMI. That's just how God made them. So we know that those breasts are not going to get any smaller as time goes on. So there's no reason, I think, to force these kids to suffer until they become 18. And it can be even more difficult as if they don't get the operation, that they find it harder and harder to stay active, and then ultimately actually can develop issues in terms of maintaining a healthy lifestyle. What does the classic otoplasty patient look like?
Yeah, the classic otoplasty patient has prominent ears, and they actually have pretty much all the structures that you want to see in terms of the ear. However, it's really too large in proportion to the rest of the face, or it cups out, or both. And so classically, you and I have been taught that we can operate on patients before they're too heavily socialized, typically around the age of 6 or 7. That's an extremely common age for children to have otoplasty or ear surgery, because we can actually pin the ears back. There are certain things we can do to actually make them look smaller, or at least optical illusion-wise smaller. And that is a great age as well as a surgeon, because the cartilage is still a little flexible. It's not ultra stiff. And so we can actually make a change. How do you feel about that versus waiting until a patient's a little older, let's say 16, 17, when puberty is done?
I think as long as you have a more mature child, I think the earlier you can get to it, if it's something that they want, the better it is. Just why continue the cycle of bullying and suffering? And I use the term otoplasty, but for the lay audience, that means ear pinning. So Dr. Roy and I always like to use the medical terminology. But I think the sooner you can address something that's just causing profound pain, psychological pain, as assuming that you can see that it's an anomaly and a little bit outside the realm of normal, I think that's helpful for children.
Yeah, totally agree. And then obviously, if the patient is younger, in other words, 6 or 7, they may have started first or second grade. They're not totally socialized, and they don't realize, especially at the age of 3 or 4, that they may have prominent ears.
Yes. And so you kind of take care of it before it becomes an issue. And we have parents coming in asking those questions. And so I think that's where it really comes down to us as the surgeon, as the physician, to have that, make sure that we are performing ethical operations, because those kids may not even realize yet that there's quote unquote a problem. And so if we're going to intervene and perform surgery on them and permanently change them before they even really have an opinion on it, we have to make sure that we're all on the same page and doing something that's going to benefit the child and first do no harm, as is our ethical and moral obligation. But that kind of comes to our last point, which is just doing important psychological screening and making sure that we always feel confident as surgeons that we're doing the right thing in this very vulnerable population. And so for me, it's like, I know when I have the patient, the parents, and I, when all three parties are on the same page, I feel like it's a green light to go ahead. If any one of those parties is not 100%, then I don't think there's a harm in waiting. And maybe we just plan for a follow-up in 6 months and keep an eye on it. Unless, of course, the one that doesn't want to do it is me for some reason. But when you've got a child looking at you, feeling very confident, parents that agree, and then you yourself see that there's something that you can help them with, then that is, 100% green light. I feel no ethical qualms about helping them.
Yeah, I totally agree. And for the listeners out there, it's not like Dr. Hamilton and I have a checklist and then we're going to go in front of the checklist, like in front of you, and just rattle everything off very sort of in a drone clinical voice. We actually have conversations. And of course, we know some of the red flags and green flags of all this stuff, but it's not like seeing a psychiatrist or psychologist or anything like that. We want to make sure that all the parties are in agreement and happy before ever considering some of these procedures in teenagers.
Yeah, and I think that keeps you safe. And sometimes we have to load the boat and maybe get a child psychiatrist or the pediatrician involved too, and just make sure that everyone's in the right mindset and to ensure that we are doing the right thing. But if we are all in agreement, then I think we've done some good work and relieved a potential psychological burden, helped get girls back on the soccer field, and that's a feel good moment for me for sure.
Yeah, it's always really, really great, especially since children heal up so much faster. So to get them back to life, to high school, to their future lives in college, it's just amazing.
Yes. So that's our mini series on teenage plastic surgery. Was it what you thought it was going to be? Was it not? Is not full of breast augmentations for pediatric population? No. So these are kind of specific aesthetic surgeries that also have functional benefits. Sometimes that can be truly life changing. So leave any comments or questions below if you have them. And as always, stay beautiful.
Stay beautiful.
Thank you for joining us on The Beauty Scientists. Be sure to visit thebeautyscientists.com and learn more about modern beauty and connect with Dr. Hamilton and Dr. Kim.